Good afternoon. Welcome to this educational session number 7, HER2 positive breast cancer, updates from the clinic and the lab. My name is Mothaffar Rimawi from the Daniel Duncan Comprehensive Cancer Center at Baylor College of Medicine, and it is my privilege to be moderating this session today. So a reminder, HER2 positive breast cancer, if it's not your intention to be in this session, this is your last chance to leave this room because we will close the doors. I appreciate the 3 people who laughed. Thank you. All right, much better. Appreciate it. So in thinking about this session, we thought that there were 3 important questions that we would like to shed some more light on with our fantastic speakers. What are the molecular determinants for response and resistance in HER2 positive breast cancer? And we've asked Dr. Ron Bose to answer that question based on his background and his work. And then, of course, what are the recent advances in systemic therapy for HER2 positive breast cancer? And that will be the task of Dr. Sherene Loi. And then novel systemic therapy options or strategies for what is, some people may think the most important or the final frontier in HER2 positive breast cancer, which is CNS metastasis. And that will be the task of Dr. Sarah Sammons. We also are joined by a wonderful panelist, our patient advocate, Mr. Lisa Shepard from Terlisa Fights Breast Cancer in Florida. So I want to welcome our panel. We will have first the 3 speakers give their talks, and then after that we will have a panel where we will receive questions from you and hopefully have a discussion. So without further delays, that was just meant to just allow more people to find their seats. I am privileged to introduce to you our first speaker, Dr. Ron Bose from Washington University School of Medicine in St. Louis, Missouri, who is a renowned researcher and physician scientist in the HER2 positive space, and is going to tell us about molecular determinants of response and resistance in HER2 positive breast cancer. Dr. Bose.
Thank you, Dr. Rimawi, for that introduction. I wanted to thank the organizers for inviting me to speak here today. Most of you have good knowledge and regularly use HER2-targeted drugs. The goal of this session is to give you a deeper understanding of these drugs so that you have more appreciation and can make better use of them in the clinic. Further, my talk will provide you an intellectual framework to think about new drugs in development. I do want to say that my talk will focus on HER2 positive breast cancer, and I will not be discussing HER2 low breast cancer. So my disclosures here. So a colleague at my medical school likes to emphasize the core concept at the beginning of each talk. And the key information that we will focus on as we talk about each drug is its target, its mechanism of action, and the mechanisms of drug resistance. And in many cases, knowing the details of the target and the mechanisms of action will often suggest relevant mechanisms of drug resistance. To remember these 3 concepts, think of the acronym TAR. So many of you know that trastuzumab was FDA approved 25 years ago in 1998. 3 key people in the development of trastuzumab received the 2019 Lasker Award in medical research. These are Doctors Michael Shepard, Dennis Slayman, and Axel Ulrich. In order to successfully develop trastuzumab, many important studies by them and others had to be conducted in the 80s and early 90s. I'd like to highlight 2 of those papers. So in 1989, this paper published in Molecular and Cellular Biology first described the mouse monoclonal antibodies that would later become trastuzumab and pertuzumab. In 1992, the process to humanize mouse monoclonal antibodies was described. And without this second paper, none of the monoclonal antibodies that we use clinically would exist. We would not have pembrolizumab, nivolumab, or any of the ADCs that we'll be talking so much about at this session and at this meeting. So with the success of trastuzumab, over the past 25 years, we see amazing growth in HER2-targeted drugs. There are now 8 FDA-approved HER2-targeted drugs there are 8 drugs for HER2-positive breast cancer, So these include 3 monoclonal antibodies, 3 tyrosine kinase inhibitors, and 2 antibody-drug conjugates. And in this review article, let's see where the pointer is. Okay, sorry. I guess I won't use the pointer. So in the review article shown on the right from by Bill Gadisher, he titled it An Embarrassment of Riches. And that was when we had 5 drugs in 2012. Now we're at 8, so things have only gotten better. So starting our focus with trastuzumab, I'm showing you the protein structure of the extracellular domain of trastuzumab. The subdomains of it are color-coded from blue through red. And trastuzumab, a portion of trastuzumab, the FAB region, is in light blue or aqua. And as you can see, that trastuzumab is binding to subdomain 4 of the HER2 extracellular domain. This crystal structure, protein structure, was solved by Dr. Daniel Leahy at Johns Hopkins University. And when I was a fellow there, I had the pleasure of working with him. He made the comparison of this protein structure to a classical sculpture of Achilles, and he kind of likened it to Achilles' heel. So I enjoy showing you this classical artwork. Now, knowing the precise location of the binding site for trastuzumab is important because alterations of the binding site are one mechanism for developing drug resistance. So target alterations, in this case, as shown in the middle panel, by generation of the P95 HER2 fragment, which loses much of the extracellular domain, including the binding site in subdomain 4, produces a resistant form of HER2. So the P95 HER2 fragment will not bind trastuzumab, but it still has an intact tyrosine kinase domain and can still signal through the PI3 kinase and AKT pathways. And the presence of the P95 HER2 has been demonstrated in patient samples, as shown on the Western blot on the right, and you can see the lower band indicated by the P95 arrow showing the presence of this. Another way that you can prevent trastuzumab binding is not by altering HER2, but is by masking or shielding HER2. So the MUC4 glycoprotein can be overexpressed in cancer cells, and when it is overexpressed, it will complex with HER2 and interfere with trastuzumab binding. So in the right, I'm kind of just trying to diagram a MUC4 overexpressing cell where trastuzumab binding is reduced or lost. A separate mechanism for trastuzumab resistance is parallel receptor tyrosine kinase signaling activation. These are also termed bypass tracks because they're bypassing the need for HER2 in some of the cases. So you can have activation of HER3 or EGFR, which are heterodimerization partners of HER2. You can have activation of IGF-1R, often through its ligand, IGF-1, and that's what's schematized here. Okay. So IGF-1R can partner with HER2 and mediate signaling down to MAP kinase AKT and PI3 kinase. Other tyrosine kinases that also can stimulate, that can also function in these bypass tracks have shown to be MET, AXL, and EphA2. Immune activation is another important mechanism of action of trastuzumab. And this can involve actions by the innate immune system, as shown on the left, with antibody-dependent cellular cytotoxicity and antibody-dependent phagocytosis, or it can involve the B and T cells of the adaptive immune system, as shown in the center or right more portion of this image. The FC region of trastuzumab interacts with several FC receptors on cells of the innate and adaptive immune system to mediate this. And margetuximab takes advantage of this. So margetuximab has 5 amino acid changes that were engineered into the FC region, which increase its binding to the activating FC receptor CD16A and decrease its binding to the inhibitory FC receptor CD32B. So think of this a little bit like the modified insulins that we make use of nowadays in the clinic. So margetuximab likewise is a modified version of trastuzumab. These modifications produce a modest improvement in progression-free survival as presented on the Kaplan-Meier curve from the most recent data from the SOPHIA trial. And the overall survival improvement is greatest in patients who are homozygous for the 158F or 158V variants of the activating FC receptor CD16. Now, talking about pertuzumab, as I mentioned, the 1989 molecular cell biology paper that first described the monoclonal that became trastuzumab also described the monoclonal that became pertuzumab. That was developed a little bit later. And pertuzumab was shown to bind the dimerization arm of HER2, which is located on subdomain 2 of the extracellular domain. By binding the dimerization arm, pertuzumab is able to inhibit HER2-HER3 heterodimerization and subsequent signaling through the PI3 kinase AKT pathway, as well as the RAS MAP kinase pathway. However, this is not the whole story on pertuzumab. In this very important paper by Yusuf Yarden, published in 2005, they looked at the effect of 2 monoclonal antibodies binding to HER2. I believe they made use of trastuzumab and a separate monoclonal that is not in clinical usage. They found with a single monoclonal antibody, they had inefficient receptor internalization. But when they had 2 monoclonal antibodies that bind to different epitopes on HER2 and thus are not competing with each other, they saw more efficient internalization of the receptor. Further, this larger antibody-antigen complex on the surface of cells would be expected to give greater immune cell recruitment, thereby also enhancing the effect. And this factor may be also important in the clinical activity that we see of the trastuzumab-pertuzumab combination in our clinical trials. So less is known about pertuzumab resistance mechanisms, but there are some that have been defined. And I want to talk about HER2 mutations. Now, many of you may have seen me use this slide when talking about HER2 mutations in HER2 negative or HER2 low breast cancer. In those cases, HER2 mutations are an activating event. However, HER2 mutations can also be found in HER2 positive breast cancer, and in many cases, those are drug resistance events, just like ESR1 mutations are found after aromatase inhibitor therapy. So the HER2 S310F mutation falls in subdomain 2 of the extracellular domain and is at the pertuzumab binding site. And mutation here causes resistance to pertuzumab, as I'll show in the next slide. Additionally, kinase domain mutations such as the HER2 L755S mutation cause resistance to lapatinib, as I'll discuss in a couple of slides, and can also cause resistance to trastuzumab, as shown in this 2017 paper listed on the bottom right from Rachel Schiffs and colleagues at Baylor College of Medicine. So data to convince you about the effect of HER2 S310F on pertuzumab is shown here. So on the left, you see a Western blot, and let me walk you through this. So what you're seeing is the use of the herregulin ligand, HRG, to stimulate HER3, HER2 heterodimerization and trigger phosphorylation of HER2. So in the second lane, since my pointer is not working, maybe I can work this here. Okay, so here you can see HER2 phosphorylation as mediated, as triggered by herregulin action. But that is blocked when you have pertuzumab present, because pertuzumab is inhibiting the HER2, HER3 heterodimerization. When you have HER2 S310F, that effect is lost. Pertuzumab, this is resistant to pertuzumab, and herregulin is able to stimulate HER2 phosphorylation because the HER2, HER3 heterodimer is still able to form. The FACS data on the right here also confirms that. So what you see on the top two panels is pertuzumab is binding to wild-type HER2 strongly, as seen on FACS, but is not binding to HER2 S310F, whereas trastuzumab, whose binding site is located distant from the mutation, there's no effect on trastuzumab binding by this mutation. So switching gears here to the HER2 tyrosine kinase inhibitors. Lapatinib, neratinib, and tucatinib all bind to the ATP binding site on the HER2 tyrosine kinase domain. Lapatinib binds to both EGFR as well as HER2, and this protein structure shown here is the protein structure of EGFR with lapatinib bound. And this is exactly where ATP would be binding if EGFR was active. Neratinib, as you may know, is an irreversible tyrosine kinase inhibitor and is a pan-HER inhibitor. Tucatinib, as you heard about this morning in the HER2-CLIMB-2 presentation by Sarah Hurwitz, is a HER2 selective TKI. So we can see the effect of HER2 mutations on these various TKIs. Let me focus your attention on the L755S mutation. This mutation renders HER2 resistant to lapatinib. The IC50 in vitro is 10,000 nanomolar or over 10 micromolar, whereas neratinib is able to inhibit the HER2 L755S, though at a slightly higher concentration than other HER2 mutations. However, neratinib can be affected by other HER2 mutations, and the HER2 gatekeeper mutation at T798 isoleucine is one mutation that does affect neratinib action. And you can see here about a six-fold shift in the IC50 when the gatekeeper mutation is present. So you may have heard of gatekeeper mutations such as an EGFR, that's EGFR T790M, and that's relevant to gemfitinib and erlotinib, and is the reason why our lung cancer colleagues make use of osimertinib. You may have also heard of the gatekeeper mutation with BCR-ABL, that's T315I, and our hematologic colleagues have changed the TKIs that they're using based on that also. And in all these cases, it's the homologous residue that is functioning to affect the TKI. Now, mutations in downstream signaling also can impact TKIs as well as trastuzumab. And so this is a pooled analysis across 5 neoadjuvant clinical trials showing the effect of PI3 kinase mutations. The path CR rate is reduced in the overall analysis when you have a PI3 kinase mutation. And we see that path CR reduction indicating drug resistance both with trastuzumab, lapatinib, as well as the combination. Parallel receptor tyrosine kinase signaling also applies to the TKIs just like it applies to trastuzumab. And in the study from 2012, you can see HER3 stimulation by neuregulin-1 causing drug resistance to lapatinib. And in several cases, EGFR stimulation by EGF treatment also causing lapatinib resistance. So the antibody-drug conjugates obviously are a very exciting area as now in HER2 targeting. And you've seen this slide or versions of this slide many times before. I want to highlight the cleavability of the linker and really how that enables us to have bystander cell killing. Because bystander cell killing is a very important property with regard to reducing drug resistance. TDXD, trastuzumab deruxtecan, is able to mediate bystander cell killing, where TDM1, which lacks the cleavable linker, does not have this effect. So the ADCs, both of them, TDM1 and TDXD, are able to overcome many of the resistance mechanisms that I've talked about already. HER2 mutations are not so pertinent with regard to resistance to ADCs because they're not falling at the trastuzumab binding site. HER2 mutations may actually increase internalization of the ADCs. Signaling pathway alterations, PI3 kinase, PTEN, parallel receptor tyrosine kinase signalings, also not so pertinent when it comes to ADCs because the ADC does not require signaling inhibition. The ADC is a delivery vehicle for getting the payload to the tumor. The immune activation probably also less relevant for ADCs. Dr. Loi will be showing some data in her presentation to address that, so I'll leave that for her. What still can be an issue when you're thinking about ADC's effectiveness and action is altered trastuzumab binding. Much more of an issue for TDM1 because of the lack of bystander cell killing. And we'll talk about P95 MUC4 in a cartoon I've got coming up. Probably less of an issue for TDXD, but not irrelevant for TDXD. But there is a new concern when you come to ADC resistance, and that's resistance to the payload. That can be mediated either by drug efflux pumps or it can be mediated by payload target mutations. So to illustrate drug efflux pumps, I'm using this diagram that's based on Mylotarg, ADC used for hematologic malignancies. But the concept is very much the same for trastuzumab-based ADCs. So you can see with internalization of the ADC, you have release of the payload, and in some cases that payload can then be pumped out by drug efflux pumps. A lot of work had been done at looking at MDR modifiers to see if they can be used to block this in chemotherapy, but I've not seen evidence that MDR modifiers can be used clinically at this point. So just to give you a kind of cartoon example to kind of bring this all home. So if you imagine a sensitive tumor with a couple of different clones developing within it. So clone 1, just for the purposes of this illustration, has a PIK3CA mutation. Clone 2 is starting to express P95 HER2, and clone 3 is starting to overexpress MUC4. So the clone with the PI3 kinase mutation will be well targeted by both TDM1 and TDXD. Clone 2 and clone 3, however, may escape the effect of TDM1 because of the impaired trastuzumab binding there. However, bystander cell killing with local production of deruxtecan may be very effective in killing these remaining resistant clones and thereby slow down the development of drug resistance. Now, if the tumor predominantly is overexpressing MUC4, that may no longer be the case. So a small subclone could be overcome by bystander killing, but if it's predominant, the situation has changed. So as I wrap up my talk, I just want to remind you to think about the drug target, the drug mechanism of action, and the mechanisms of resistance as you're thinking about existing drugs. And when you're hearing about novel drugs, I encourage you to ask about this. At the very least, ask about the drug target. I don't know how many presentations I've sat in with either drug reps or with my clinical trial teams. They tell me the drug name, and then I ask them, what does it do or what does it bind? I don't know. Please, understanding the drug will allow you to use it intelligently and to think about where to go next with it. So I want to end on a humorous note. So 5 years ago, our local Susan Komen affiliate had a fundraising event where they encouraged us to dress up with silly pink wigs. And so I got this crazy pink wig, and I dubbed myself Dr. Pink Einstein. And it was pretty effective in raising money for our local chapter. So Dr. Pink Einstein wishes you an exciting and enjoyable San Antonio meeting. Thank you.
Thank you, Dr. Bose. That was spectacular. Our next speaker is Dr. Sherene Loi from Peter MacCallum Cancer Center in Melbourne, Australia. And Dr. Loi is, of course, a well-known translational researcher, and she's going to tell us today about advances in systemic therapy for HER2-positive breast cancer. Dr. Loi.
Thank you. Good afternoon, everyone. So thank you, Dr. Bose, for that lovely introductory talk, and Dr. Rimawi for the invitation to be here today. So we're going to talk about recent advances in HER2-positive systemic disease. These are my disclosures. Okay, so I also have a picture of Achilles. But my analogy is a little bit different, and I like to think of HER2-targeted therapies as being the arrow. So, precision medicine is all about, has been about discovering specific tumor genetic alterations that really are key for driving tumor growth, and this allows development of specific targeted therapies. So HER2 is probably one of the poster child examples. There's also EGFR mutant lung cancers, BRAF melanomas, etc. So, we're targeting this specific mutation is very important for the cancer and is its explicit vulnerability or Achilles heel. So HER2 amplified disease, we know, is around 15% of breast cancers, and really HER2 targeted therapies have really changed the natural history of this once aggressive disease. And I'll just point out that it's actually quite rare to lose the oncogenic driver in a tumour that's truly addicted to HER2. So this is the rationale for the sequencing of HER2 targeted therapy. We still see heterogeneity, and it's possible to see subclonal HER2 amplification, so, a small clone that is amplified, but generally it's rare to lose the driver. So, just remember that when we're thinking about our patients with this disease. So these are the guidelines from 2014, and you can see there in the first-line setting was trastuzumab, pertuzumab combinations from the Cleopatra study, but trastuzumab chemotherapy was also there at that time. Fast forward 10 years, and we have now a very complicated algorithm, and taxane, trastuzumab, pertuzumab firmly still placed in the first line, but there are now multiple lines of HER2-directed therapy which offer clinical benefit and improve survival for patients with progressive HER2-positive advanced disease. Optimal sequencing is not known, so how can our lab colleagues help us with that? And also some patients who are diagnosed with advanced HER2-positive disease experience very long survival these days, which is great for patients today. So just one slide on the Cleopatra study, which remains a standard to this day for the first-line metastatic patients. And these data were published in 2020, now with a median follow-up of 99 months, and remarkable data which show that there are 37% of patients alive and 16% of patients progression-free at 8 years, so still receiving trastuzumab and pertuzumab monoclonals in that particular study. And so who were these patients? These patients were more likely to be PR positive. They were more likely to be HER2 plus 3 IHC, so highly addicted presumably, more likely to have de novo presentation and low volume disease, more likely to be PIK3CA wild type, higher HER2 MRA, and higher levels of TIL. So this might give us an idea on which patients who present stage 4 that we can be more aggressive, perhaps with their upfront therapy. So recently we've seen the remarkable waterfall plot from the first presentation of these data with TDXD, and you can see a number of interesting factors with this particular molecule. You know, patients that progress, there are very few patients that have upfront de novo resistance to TDXD, and I think Dr. Bose has very elegantly summarised some of the reasons why that may be so. And this study was from a later line population. You can see there that patients had received, you know, trastuzumab, mostly pertuzumab, as well as TDM1, so, and their response rates, you know, 62% confirmed overall response rate. So truly remarkable in the later line setting. And this was followed by the pivotal phase 3 study, which again showed these remarkable progression-free survival curves, so tripling of benefit with TDXD. So of course this was also associated with improved overall survival, but I think also important to understand that many of the patients that received TDM1 in the control arm had received a number of lines of microtubule combination agents in combination with trastuzumab previously, so that may explain a little bit why the control arm did as poorly as is shown, but still a very, very highly efficacious medication in the second line setting. So with regards to toxicity, you can see there the interstitial lung disease, all grades 15%, and nausea, all grades 77%. So of course this is not to be ignored, because having low-grade nausea is not a pleasant thing to live with, and alopecia there at around 40%. So again, improvement on some of these agents that cause hair loss, but still there is alopecia there, and you know, I generally do warn patients that they will experience some hair loss whilst on this treatment, which may get worse with the longer duration. So the later line study, Destiny 2, which showed superiority to standard of care in later line setting. Again, similar hazard ratio in the later line setting, similar also for overall survival. And also, interestingly, very similar side effect profile, 10% all grade interstitial lung disease. And again, 3/4 of the patients had low-grade nausea. So these things, again, are important for patients' quality of life, particularly when they're on this treatment for a long period of time. In this study and in the Destiny 3, around 20% of patients discontinued the medication due to an adverse event. So again, that's important to understand if potentially we can re-challenge these patients in the future, and if they may experience the adverse event again. So speaking of adverse events, I think this study was very nice, that was recently published last year, which shows the rate of interstitial lung disease and pneumonitis in a pooled analysis of 9 TDXD studies. And as you can see, there's a very sharp rise in the first 12 months, and then a plateau after 12 months. So the overall incidence here was 15% all grades, and 87% of their patients had their first event within 12 months of their first dose. So I think this helps educate us with more intense monitoring in the first year. And then these authors also looked at the factors that may predict interstitial lung disease, and they concluded that age, ethnicity, lung comorbidities such as smoking, interestingly abnormal renal function, time from diagnosis and dose and baseline oxygen saturation were all associated with higher risk of developing pneumonitis. So again, a little bit more information to help us understand who to more closely monitor when on this particular agent. And of course, there are guidelines now that we should be stopping TDXD on the development of grade 2. So grade 1 is often picked up asymptomatically on your routine restaging CT. So again, that's something that you can watch closely, but grade 2 you should definitely stop. Okay, so ongoing trials. So what's going on in the future for HER2-positive disease? How more can we improve? So there's Destiny Breast 09, which is going up against the Cleopatra regimen. So this is THP versus TDXD and pertuzumab. So again, there is some rationale for combining TDXD with pertuzumab, more efficient internalization, etc. Interestingly, there's no immunotherapy arm in this study, and I think it will be quite interesting to see how TDXD performs in the first-line setting when patients have a very good immune system at this point in time, if we're assuming that a lot of the benefit of THP is also related to a good immune response. In the early stage disease, we have Destiny Breast 11, which is the neoadjuvant phase 3 study. And as you can see there, this is neoadjuvant TDXD by 8 cycles. And then we have a combination, and this goes up against ACTHP. So, again, I think it's a little bit disappointing there's not a shorter duration arm here. Patients are going to be automatically assigned 24 weeks of TDXD, but perhaps a step forward in that there is potentially less associated side effects with TDXD as monotherapy. And then we have the residual disease studies, Destiny Breast 05, which is looking at TDXD in the post-neoadjuvant setting. It's so similar to the Catherine setting, which updated data will be presented on Friday. This is 1 year of TDXD versus TDM1. Again, 12 months as an arbitrary thing, as we like to do in breast cancer, and it'll be interesting to see how this agent compares with regards to safety during radiation, for example, myelosuppression, tolerance. Perhaps the nausea will be a bit too much for patients after the early neoadjuvant and adjuvant therapy. And of course, efficacy related to TDM1, given how efficacious TDM1 has been shown to be. And then there's Astafania, which is looking at TDM1 plus immunotherapy in the post-neoadjuvant setting. So is there any data that helps us understand how to position TDXD or how to sequence TDXD or what we should give for patients who progress on TDXD? Because despite those very impressive progression-free survival curves, people are still progressing on TDXD. I think my longest patient went for about 5 years on TDXD, but ultimately did progress in the CNS. So to help answer this question, we've been doing some preclinical work, and we've just created some TDXD resistant cells by treating cell lines in vitro for over 6 months and making them resistant, as you can see there. And then generally, if you don't know what's going on, you do an RNA-seq. And so this is the RNA-seq here. And in both TDXD-resistant cells, the top gene that was reduced was topo1. So, that seems very logical and very nice to see that. And you can see there in both lines, you have reduction of the topo1 gene in the resistant lines. And interestingly, we did see some reduction in the HER2 protein in one of the TDXD-resistant cell lines and not the others. So anecdotally, we have been seeing this a little bit in the clinic in patients that we've re-biopsied post-TDXD. They do seem to have a reduction in their HER2 protein. But does that mean anything? So then we went to test these cell lines to other therapies. And so you can see here that these cell lines, compared to their parental line, were resistant to the payload, TDXD, so that's not surprising. And interestingly, were also resistant to sacituzumab, which has the same payload, the topo1. But when we tested these lines against TDM1 and tucatinib, we found that these lines will still remain sensitive to TDM1 and tucatinib. So, I think this gives us some reassurance, and it could be that TDM1 is a different payload than the TDXD, but it's interesting that these cells were perhaps more sensitive than the parental cells to tucatinib, which, despite some reduction in the HER2 protein, still suggests that these cells remain addicted to the HER2 oncogene pathway for growth and proliferation. So I'm not going to labour too much on the HER2 climb study, but obviously this is now an approved combination, and thankfully it does seem like it will still be efficacious post-TDXD. These are the curves here, and they're all results this morning from HER2 climb 2, which is TDM1 and tucatinib, and so I might leave it to Sarah to discuss how that might be incorporated, because I'm still trying to work that out myself. So immunotherapy. There's strong rationale to combine HER2 targeted therapy with particular PD-1 inhibitors. The TIL has high expression of both PD-1 and CTLA-4, very low expression of other checkpoints. And there's a lot of data now which suggests that the association of immune infiltration is prognostic, but also very interestingly in this particular study, which was the short HER study, that if patients had a high level of TIL infiltration, they could get away with 6 months versus 12 months of therapy. So the immune response at baseline is important for helping us with the patient's prognosis and potentially treatment. But certainly there's strong rationale there to combine, and we've looked at this in the KATE-2 study, which is the combination of TDM1 and tislelizumab. Originally, we looked in the ITT population, enrolled an unselected population, but subsequently, as we learned more about immunotherapy, the benefit of atezolizumab is confined to the patient with pre-existing immune response, so in this case, PD-L1 positive. And there's a number of papers in the preclinical setting suggesting that TDM1 does combine well with PD-1 targeted therapies in the preclinical space. So the question is, what about TDXD? Can that enhance our immune response? And again, we've been looking at that because that's, of course, my favourite subject. And then we have this data here from an immunocompetent mouse model, and it displays very nice dose-dependent efficacy to TDXD. This mouse model is trastuzumab resistant. And then if we look at the immune infiltrate post-treatment with TDXD, we see this very nice dose-dependent increase in the immune response. So the bigger the dose of TDXD, the lower the tumour burden and the increase in the immune response. And this is across the board, T cells and B cells, DC cells, etc. So it provides good rationale that combinations will be helpful. Does TDXD efficacy depend on the immune response? So, trastuzumab, it's been shown if you deplete NK cells, you don't get any effect of trastuzumab. What about TDXD? So I'm not going to give the whole story away, but this is data from a non-skid gamma mice. Oh, and I'm missing a curve. It's not meant to look like that. Oh, well. So you're going to have to believe me, there actually is a curve that starts to rise. That falls, and then it starts to rise at about 20 days. So non-skid gamma mice lack mature T and B cells and NK cells, but there is some efficacy there in an immunodeficient mice. So it does suggest that TDXD does work despite not having immune cells, but not as well. So again, there's good rationale here to combine TDXD with an immune agent. In my view, and from what we've learned so far, this is likely to be best placed in a neoadjuvant setting. There is some data in the Destiny study that's yet to be presented, but with single-arm studies, it's really very hard to assess efficacy of an immune agent combination because we know now the effects are generally on long-term survival. So tucatinib is the same. We've also published data with regards to, again, if you inhibit the oncogene, it does result in an increase in change in a tumour microenvironment, which is T-cell mediated, and this can be harnessed with combination PD-1 therapies. And I think, ultimately, this will help the patient with regards to overall survival. And we know that exposure to immunotherapy agents can help patients with regards to improving their response to the next agent and changing their outcomes in TNBC. Okay, so this is all preclinical, and we do have the Impassion 050 study, which was the neoadjuvant early stage study that was presented last year at an ESMO plenary session. And this was atezolizumab in combination with neoadjuvant chemotherapy, so AC followed by paclitaxel, trastuzumab, pertuzumab, atezolizumab, or placebo. So neoadjuvant study with PCR being the primary endpoint. So this was a very negative study, as you can see there. There was no benefit for the addition of atezolizumab in this study. Nothing was seen with regards to PD-L1 status as well, and so this was quite disappointing for the field. But if you really drill down into the data, this regimen did seem to be quite toxic. It was also performed in a time of COVID, so there were 5 deaths in the investigational arm, and there were many more grade 3 to 5 adverse events and discontinuations in the investigational arm. So, you know, I'm taking away from these and some lessons that I think we should learn in breast cancer when we're looking at combining immunotherapy. We really need to stop adding on immunotherapy to our standard chemotherapy regimens, you know, especially with overlapping toxicity. We know pertuzumab has diarrhea. We know the addition of immunotherapy agents also has diarrhea. You know, adding them together along with myelosuppression is really, you know, it's not surprising that you do get all these adverse events. And all these adverse events resulting in drug delays and discontinuation is all adverse to the generation of a good immune response. So I think really moving forward in the field, we really need to think about less chemotherapy, less myelosuppression, and look at combinations that have non-overlapping adverse events and less add-on trials. And now we kind of know who, you know, with patients who are immune enriched, they're going to get a better response from immunotherapy in the setting of less chemotherapy. So, you know, I think we know enough now about breast cancer to help us make our future trials of immunotherapy better. So in conclusion, there have been recent significant advances in the treatment of HER2-positive breast cancer, and for patients this is great news because they are living longer. And you know, I have many patients now in my clinic that come, you know, and have been coming now for, you know, nearly 10 years, so that's great. How to treat patients post-TDXD is under investigation, but it does seem that tucatinib and T-DM1 are likely still to be efficacious. You know, I think as we move forward in HER2-positive breast cancer, we really need to be a bit cleverer, stop thinking about treating everybody. We know now who does well and who does poorly. We really can better define the group that we can de-escalate and escalate our treatment in the future. And with regards to immunotherapy studies, I personally think there's really a lot of room to move there, and we really need to think hard about our design in order to bring forward an efficacious and potentially also curative therapy for patients who need it the most. And we can learn a lot from what we've learned in TNBC, where IO is best placed up front. So I thank you very much for your attention. I'd like to acknowledge my funders as well. Thank you very much.
Thank you, Dr. Loi. That was great. Our third speaker is Dr. Sarah Sammons, clinical and translational researcher from Dana-Farber Cancer Institute, and she is going to talk to us about approaches in the management of CNS metastatic HER2-positive breast cancer. Dr. Sammons.
Thank you so much, and thank you to the conference organizers for having me to discuss this topic that I'm very passionate about. So today we'll be talking about strategies and systemic therapy strategies for HER2-positive brain metastasis. These are my disclosures. It's no surprise to anyone in this room that brain metastases are a major clinical problem for our patients that have advanced HER2-positive breast cancer. In this pooled analysis of multiple retrospective and prospective studies, about 1 in 3 patients with metastatic HER2-positive disease will develop brain metastasis. And some autopsy studies actually even show higher incidences, more like 1 in 2. So it's a major problem. But when throughout their course does this become a problem? When is this something that we have to worry about? Is this something we should be screening for? In an analysis that we did with Flatiron that we'll be presenting tomorrow, we looked at the incidence of brain metastasis in metastatic breast cancer patients per line of therapy. And in almost 16,000 patients with metastatic breast cancer, about 4,000 patients with metastatic HER2 positive breast cancer, what we found was that the incidences did vary based on the hormone receptor status. So at up to 5 lines of therapy, about 26.5% of people with hormone receptor positive, HER2 positive breast cancer will develop brain metastasis. And in the hormone positive subtype, this generally increases per line of therapy. In the hormone receptor negative HER2 positive subset, the rates were actually higher. 37% of patients by 5th line of therapy will have a brain metastasis. And these incidences actually happen quite early. Most patients with hormone receptor negative HER2 positive breast cancer that were going to develop a brain met developed it by the 3rd line of therapy. So it was a rather early event. Once a patient develops brain metastasis, we have multiple goals. First and foremost, to palliate and prevent neurologic symptoms from happening, which can obviously lead to substantial morbidity. We want to prevent neurologic death and certainly neurologic decline. We want to prevent subsequent CNS events, both brain metastasis and leptomeningeal disease. We, of course, want to improve their overall survival. And then concurrently, we have to worry for the vast majority of patients about controlling their extracranial disease, which is an equal challenge. And we want to prolong the amount of time until they need other local therapies that have side effects, like whole brain radiation therapy or stereotactic radiosurgery. For brain metastasis, really our main tool, one of our major tools, is using local therapies, such as radiation therapy or sometimes surgery, which provides excellent local control to HER2 positive brain metastasis. This is a nice algorithm from ESMO that was published in 2021, just showing a little bit how we think about local and systemic therapies for HER2 positive brain metastasis. For patients that have a single brain metastasis, if they're otherwise doing extremely well, have a good KPS, not much extracranial disease, we will consider intracranial resection, followed by radiation to the surgical bed. For multiple lesions, we're really looking mostly at radiation therapy. There's marked institutional variation on up to how many lesions radiation oncologists will consider stereotactic radiosurgery. But for multiple lesions, SRS is generally recommended, and for extensive multiple lesions, sometimes more than 6, sometimes more than 10, sometimes even more, whole brain radiation therapy, which is very morbid, is still recommended. More and more we're thinking about, given how effective our therapies are becoming for brain metastasis, can we defer local therapy for some patients that may benefit from deferring, whole brain radiation or large volume SRS? And there's some nice guidelines from ASCO that was put out in 2022 about which patients we may consider deferring radiation therapy and just trying a new systemic therapy. And I did this in the clinic just this week. We are starting to do it in the patients that we feel comfortable, and this obviously is a decision to be made with the multidisciplinary team of a radiation oncologist and the patient. But it could be considered in patients that have a favorable prognosis, that have asymptomatic small lesions, generally less than 2 centimeters, no symptomatic disease from mass effect. And this is really the most important point for me. These patients have the option to proceed on a therapy that they have not had before that has excellent intracranial activity. And for me, that's really limited to TDXD or HER2 Climb. But I think that we're thinking about this more and more for a couple of reasons. The most impact for our patients with metastatic HER2-positive brain metastasis has really come from systemic therapies. We know that systemic therapies that target HER2, nearly all of them improve overall survival when we give them to patients after their local therapy. And this is a meta-analysis of 97 studies using HER2-targeted therapies, really showing that patients that have brain metastasis, their survival is dramatically improved if we give them systemic therapies. So we can't just be thinking about local therapy, we need to then offer systemic therapy to all of them. And when we're thinking about systemic therapies and in clinical trials, we are now seeing more and more brain metastasis subgroups, which is excellent. We think about them clinically in two different ways. We think about the stable brain metastasis population, which is generally those that have been treated with local modalities and have non-progressive disease, or those patients with active brain metastasis that are unsymptomatic, asymptomatic, but their lesions are untreated, or they've been treated with radiation, but they continue to progress. And we see that breakdown that I'll show you subsequently based on these two clinical categories. Our goals for systemic therapy for these two clinical categories are different. So for patients that have active, untreated, or treated yet progressive lesions, we really need an intracranial response to prevent the morbidity of neurologic complications. And so we really look for agents that have higher intracranial response rates, which is why it's so important to include active brain metastasis patients on trials so we know what that is, so that we can avoid the morbidity of proposed local therapies like whole brain radiation. So we would prioritize agents with those high intracranial response rates, long CNS progression-free survivals, and of course, we always want to see an overall survival benefit. For patients with stable brain metastasis, our goals are a little bit different, but I think of stable brain metastasis is a very heterogeneous population that I'm going to talk a little bit more about. But for patients with stable brain metastasis that have some high-risk features, I think prioritizing agents that have long CNS PFS and overall survival benefits in the brain met subgroup is very important. So when I think about patients with stable brain metastasis, they are all lumped in one category, but we know that a patient that has one brain metastasis and who doesn't have another brain metastasis event for 10 years is very different than a patient presenting with 7, 8, 20 brain metastasis, or that has a short interval area. So interval between their SRS and their new brain met. There is a poster session tomorrow and some data that I'll discuss that really tries to tease down who are the most high-risk HER2 positive stable brain mets patients. And the way we look at that is by looking at which patients with HER2 positive brain metastasis are at highest risk of dying from their brain metastasis or neurologic death. Also, patients that have a fast brain metastasis velocity, which is a published and established term, which is used by calculating, by dividing the number of brain metastasis after their first SRS by the total time in years that have elapsed since that period. So patients that have a very high brain metastasis velocity, you gave them radiation and then they have a new brain metastasis 6 months later. Those are higher risk patients with stable brain metastasis that I think need our attention and need the better agents. Nearly half of our patients with HER2 positive brain metastasis will die from neurologic death. They will die from their brain metastasis. This is a study that was done by our colleagues at Dana-Farber, Brigham and Women's, looking at the risk of neurologic death in patients with breast cancer brain metastasis. What they showed among subtypes of breast cancer is that those with HER2 positive brain metastasis have the highest risk of neurologic death compared to triple negative or estrogen positive brain metastasis, and 40 to 50% of them will die of their brain metastasis. Another additional risk factor for neurologic death in patients that have brain metastasis was the number of brain metastases, and the risk of neurologic death increased with each brain metastasis that occurred. Also, upfront use of whole brain radiation was also associated with risk of neurologic death as well. And conversely, having a excellent performance status or having progressive extracranial disease lowered the risk of neurologic death. So we worried about them in their brain metastasis a little bit less. And so how do we help these patients? Most of them will still have local therapy unless we're trying to avoid it or deferring, like I previously talked about. But it's incredibly important to put these patients on systemic therapy after local therapy, or of course if you're deferring local therapy. And the most active agents are antibody drug conjugates, HER2-targeted TKIs, and now we have the combination of both that we'll discuss today. I think one of the most exciting findings in the last couple of years has been that antibody drug conjugates, which are bulky molecules, do actually get into the brain, which has been extremely exciting for us and our patients alike. We first learned this with TDM1, and this is some preclinical data just showing that TDM1 in mouse models of HER2-positive breast cancer does in fact have activity in patients with brain metastasis. In HER2-positive tumor-bearing mouse model, intracranial models with brain metastasis, giving TDM1 versus an anti-CD22 DM1 did improve survival in those mice. And then we know, mostly from the Camilla phase 3b clinical trial of 2,000 patients treated with TDM1, about 400 of them had baseline brain metastasis, and 126 of them had measurable brain metastasis. We saw that there was an actual intracranial response in a fifth of the patients. So the intracranial response rate of TDM1 is about 21%, with an intracranial clinical benefit rate of 43%, and a median progression-free survival of 5.5 months. So we did learn that TDM1 is active in the brain. And then subsequently, we now have TDXD, which we're learning more and more about, but we've also learned that TDXD has excellent activity in the brain. So on the left, this is a preclinical study from my previous colleague, Shahiriyar Kabraji, that was published in Clinical Cancer Research, looking at the intracranial efficacy of TDXD in HER2-positive brain metastasis models, showing improved survival in the mice that got them. And then on the right is unpublished data from the lab of Jean Zhao and Natalie Agar, basically showing that the deruxtecan payload also does get into the brain metastasis. The deruxtecan payload also does get into the brain metastasis. We know from DESTINY-Breast03, who included patients that had stable brain metastasis, that TDXD compared to TDM1 prolongs RECIST 1.1 extracranial progression-free. We know from DESTINY survival, in that study, DESTINY-Breast03, who included patients that had stable brain metastasis, that TDXD compared to TDM1 prolongs RECIST 1.1 extracranial progression-free survival. In that study, they also looked at the patients that had brain metastasis that they saw had measurable disease in the brain, and they did see responses in those patients. I think the caveat here is that the vast majority of those patients did have radiation to those brain lesions, so it's a little bit hard to know, that what those responses were. But this has further been validated in several other small studies of active HER2-positive brain metastasis patients, such as Tuxedo 1 on the left, Deborah in the middle, and a retrospective prospective collaboration between Duke Dana-Farber and MD Anderson, showing that the use of TDXD in active HER2-positive brain metastasis is quite good, with intracranial response rates ranging from 44% to 73%, which is quite good. We also saw in the pooled analysis that Sarah Hurwitz presented at ESMO this year. They pulled DESTINY-Breast01, 02, and 03, and they looked at the patients that had brain metastasis, and they looked at intracranial response rates, they looked at CNS progression-free survival, which in my mind is really secondary prevention, the time until a next brain metastasis occurs. And what they showed was that TDXD compared to the control arm performed very favorably in terms of CNS prevention, or CNS PFS, in both patients with treated stable brain metastasis, but it performed extremely well in patients with untreated and active brain metastasis as well, with a hazard ratio that is quite impressive. We've been talking about this and what this means. Active brain metastasis patients do not have an intact blood-brain barrier. They do not have an intact blood-tumor barrier. So molecules are more likely to get into the brain of these patients, and we're also more likely to see a response in active brain metastasis, because the lesions are not burned out as they are in patients with stable brain metastasis. So there's actually tumor there for us to see a response. And I just think this really speaks to the fact that with guardrails, that active brain metastasis patients should be included in clinical trials, and TDXD is performing very well in patients with both stable and active brain metastasis. Another thing that I thought was very interesting from Dr. Hurvitz's presentation at ESMO is that you can see that in the patients with baseline brain metastasis that received TDXD, 43% of them had their first progression event in the brain. So even though it's working quite well, we still are seeing progression events in the brain. We still have more work to do to figure out why and how we can best treat and prevent this. This is a cohort series that I published between Duke and Dana-Farber with one of my fellows, showing that TDXD also works quite well for HER2-positive leptomeningeal disease, which is not arguably our largest clinical challenge. And we have patients with HER2-positive leptomeningeal disease that have been on TDXD for well over 18 months to 2 years now, doing quite well. So that's exciting too. Another point that I want to make is that, the therapies the local therapies, even though they're very effective for HER2-positive brain metastasis, are not without harm. We're learning a lot about radiation necrosis, which is a common side effect of stereotactic radiosurgery. And in a very recent letter published in JAMA Oncology, the Memorial Sloan Kettering group looked at the incidence of radiation necrosis when SRS was delivered around the time of an ADC, either within 7 days before or within 14 days after. And what they found was that the risk of radiation necrosis was higher when we delivered an ADC around the time of SRS. So we have a lot of questions. Further research needs to be done. This was one study. But I do have a lot of questions about how to best sequence radiation in ADCs. The study also showed that it was more common in the large volume lesions to develop radiation necrosis around the time of an ADC. The smaller lesions did pretty well. What's the optimal timing between SRS and ADCs? Are all ADCs the same? Is TDM1 the same as TDXD? And given the excellent activity of TDXD in active brain metastasis, should we push the limits of delaying SRS and SRT in some patients when we think that it's safe? Now moving on to HER2 tyrosine kinase inhibitor combinations, we've known that these are small molecules, they get in the brain, they're most favorable, they're very favorable for our patients with HER2-positive brain metastasis. I'm not really going to belabor the HER2 CLIMO-2 study very much because we've seen it for several years now, but tucatinib, trastuzumab, and capecitabine is an excellent option for our patients with both active and stable brain metastasis. The intracranial response rate of this combination is about 47%, and we know that tucatinib added to trastuzumab and CAPE improves both intracranial overall response, it improves CNS PFS, PFS by RECIST, and overall survival in both stable and active brain metastasis patients, and it's a very good option. We've also seen a smaller study by my colleague Rachel Freeman adding the combination of neratinib with capecitabine in active HER2-positive brain metastasis patients. They had two cohorts. One cohort was treated with prior lapatinib, and the other had not had prior lapatinib. And essentially in the patients without prior lapatinib, we see a CNS overall response rate of about 50%, whereas in the lapatinib pretreated, there was still a pretty good overall response rate in the CNS of 33%, PFS of 5.5 months in those who had not had prior lapatinib. So neratinib, capecitabine could still be an option. For some patients, it's fairly toxic, and so we have to think about that. The next question, and I think a very timely discussion given that we saw HER2 CLIMO-2 today, is will ADCs and TKIs be feasible, and will they add benefit to our patients with HER2-positive brain metastasis? By the same authors that did the neratinib capecitabine study in active brain metastasis, they also looked at neratinib and TDM1 in active brain metastasis patients. There were 3 cohorts here, and one thing I want to point out is, so cohort 4A was previously untreated with TDM1. Cohort 4B had prior TDM1, and cohort 4B had no prior TDM1 but was previously treated, and cohort 4C had prior TDM1. And you can see that there are respectable intracranial response rates of 33% in the untreated cohort. But even the patients that had prior TDM1, if you added neratinib to the TDM1, there was an intracranial response rate of about 29%, which I think is interesting. And then today, Dr. Hurvitz presented the results of the highly anticipated HER2-CLIMB-02 clinical trial, which is a phase 3 randomized clinical trial of tucatinib added to TDM1. 43% of the patients in the clinical trial had brain metastasis at baseline. 22% of those patients had active brain metastasis and 21.5% were stable. We see an improvement in progression-free survival that is really mostly impressive in the brain metastasis population, in my opinion. You see a CNS PFS, you see a median RECIST PFS of 7.8 months with the addition of tucatinib to TDM1 and 5.7 months with TDM1 alone. We don't have any data on intracranial response rates, CNS PFS, overall survival in the brain metastasis population, but that's highly awaited. So here's just an inclusive list of HER2-directed therapies that have the highest intracranial response rates for our patients with active brain metastasis. At the really top of the list is T-DXd and tucatinib, trastuzumab, capecitabine. Those are our most active agents for our patients that are facing this difficult problem. Pyrotinib, which I did not talk about today, also has excellent intracranial response, but is not available, at least in the USA. And here's another table laying out the CNS PFS for our patients that I think about this more for our patients that have stable brain metastasis, particularly those with high-risk features. And again, at the top of the list is T-DXd and tucatinib, trastuzumab, capecitabine. So when I think about HER2-targeted systemic therapies for our patients with HER2-positive brain metastasis, first line for most patients is still a taxane, pertuzumab, trastuzumab after local therapy. I think for our stable brain metastasis patients that are of usual risk, low number of lesions, no particularly high-risk features, I think the usual algorithms apply. For most of those patients, T-DXd is going to be the option in the second line. For our patients that have stable brain metastasis with high-risk features or those with active brain metastasis, I think in the second line, T-DXd or tucatinib, cape, and trastuzumab are just fine options, and I would have a discussion with the patient. It doesn't matter which one you use first. Our patients will need more than one therapy, and I'm just very glad that we at least have 2 effective therapies. Dr. Loi showed great data that tucatinib probably has activity after T-DXd, so that's definitely reassuring, and we have 2 great options for these patients. In the third line and beyond, you just switch to whatever one you didn't use in the third line. We now have TDM1 tucatinib as an option as well, but the value of that post-HER2-CLIMB is unclear, so we await further data on that, and also to understand if tucatinib continuation for these patients could be helpful. On the horizon, we have multiple HER2-targeting ADCs. We have more HER2-targeting tyrosine kinase inhibitors that are highly brain penetrant. There's even HER2 CAR-T trials for HER2-positive brain metastasis and LMD ongoing. And this list is not exhaustive, but there are many more ADCs in development, and we know that many of them get into the brain. The next generation ones do, which is extremely exciting. So to conclude, brain metastasis and HER2-positive breast cancer are common. About 1 in 3 patients will develop them. ADCs, new generation ADCs, can get into the brain and quite well. T-DXd and tucatinib, cape, trastuzumab are the most active agents in our patients with stable, active, and HER2-positive brain metastasis. And further study of radiation necrosis and optimal sequencing of local therapies with ADCs are needed. And new strategies post-T-DXd and tucatinib are also highly anticipated.
Thank you, Dr. Sammons. That was really great. And I want to really thank the three speakers for a tour de force of all things HER2. It was really a spectacular group of talks. Before we get to the microphones to ask questions, I want to welcome again our patient advocate, Ms. Terlisa Shepard, and invite her to share with us a few things about herself and her activities and her personal story. Terlisa, the microphone is yours. It's up to you.
Hello, I am Terlisa Shepard, and I am a 25-year HER2 positive breast cancer thriver and patient. "22 of those years have been surviving with metastatic disease. And that's messed to my bones, lungs, liver, spine, abdomen, and brain. I've been living with surviving a brain mets since 2003, 20 years ago. Awesome. I was also pregnant with my daughter when I was first diagnosed in 1998. I didn't think I was going to see her grow up, even get out of elementary school. That baby is 25 years old now. My oldest is 27 years old. I am thankful for the continued updates that we have here with the HER2 positive disease. And one of the things as a HER2 positive patient, just understanding the triggers that goes along with this disease, progressiveness that goes in with it. I know me myself, I was diagnosed first with metastatic in 2001, and actually was given a prognosis that I wouldn't make it, to go home, quit work, and get my life in order. Then in 2002, diagnosed again. In 2003, diagnosed again. So I was looking around, wondering, when was that ball going to drop again with some other diagnosis, and even now with a metastatic disease. So again, like I said, I'm very thankful for the updates from the clinics and the labs that we have going on today. And as I would love to put it, like my friend, co-survivor, patient advocate, Dr. Kelly Shanahan, not dead yet.
Thank you. Thank you, Terlisa. I mean, patient advocates like you give us inspiration, give us guidance, and certainly keep us on the track to where the story of every patient with HER2-positive breast cancer, or all breast cancers, is your story, a story of overcoming and success. So thank you for sharing that with us. It was really inspiring. Now, I would like to invite questions. People could step up to the microphones. It's a little hard for us to hear up here, so if you could speak directly into the microphone, we'd appreciate it. While people think about their questions, I can think of a few. So, Ron, you talked about several mechanisms of action, resistance, and I think many of us have seen and have worked on biomarkers of response and resistance. How do you see that coming together to help guide selection of therapy and maybe, escalation, de-escalation, now called optimization? How do we get those interesting and exciting biologic facts into practice? Some of them are making their way in, but some are not.
I think that's been a challenge. So ctDNA measurements can provide you information on mutation profiles that maybe you could make use of in metastatic disease management, but in the vast majority of cases, understanding on an individual patient level what resistance mechanisms are occurring is not largely done, because most of the time that would require metastatic biopsies. I think our sequence of drugs makes a lot of sense with what we've learned, starting with the Cleopatra regimen as our first-line metastatic regimen, moving to an ADC, TDXD in our second line, and in many cases bringing in a TKI as our third line. So we're cycling through the available categories of agents. I think that, has been Dr. Hurwitz mentioned this morning that when she started practice in 2007, she would reuse trastuzumab and lapatinib with other chemotherapy backbones as part of her approach to managing patients. Now we have more HER2-targeted drugs. Certainly we do reuse trastuzumab and TKIs, but we can be using all of the things within our armamentarium before we have to cycle back to a drug.
Great, thank you. And I agree with you. We want to see how this biology helps guide it rather than going line by line. How do we refine these choices? And people are doing a great job clinically, but it would be good to incorporate biology. Question from audience, please, go ahead.
Hi, I'm Dr. Chen from National Taiwan University Cancer Center. I have two questions for the panelists. The first one is regarding the triple positive patients. Are there any new mechanisms or new suggestions on how to select drugs after they failed like THP? Do we have any clues that whether the tumors are progressing because of the HER2 positive component or its ER positive components? Are there any new updates on this issue? And the second thing is, are there any suggestions on whether if we should do re-biopsies when the tumor progressed? Will they provide new information regarding which drug we should use next?
Okay, thank you. So the first question about triple negative breast cancer, Sherene, you want to take that one? Triple positive, I'm sorry.
Yeah, so that's a great question. So there are trials, one of which we'll read out next year, the Patina trial, which is looking at CDK4 maintenance therapy in patients after a Cleopatra regimen. So yes, there are biological differences, and there is good preclinical rationale that a CDK4 inhibitor works very well in HER2 positive disease and particularly HR positive disease. So there are a number of trials, PIK3CA mutant, etc., looking at that HR positive, HER2 positive subtype. With regards to your question of what's more luminal as opposed to what's more HER2 enriched, perhaps assays such as PAM50 might help us with that. I like to look at the HER2 +3 IHC as well as copy number to help me try and work out if the patients are more HER2 driven than hormone driven. But we do see this balance, right? If your hormone therapy can increase your HER2 levels and vice versa. So that may become more relevant as we biopsy more patients post TDXD. But whether these patients are truly losing their oncogene addiction, I'm not sure about that. So I doubt that to be true.
Okay, thank you. And thoughts on biopsying the patients line after line? Repeat biopsies.
Yeah,
I know you kind of alluded to it, but I think that was...
Yeah, so, I mean, we've been biopsying patients post-TDXD because we don't know what's going on. And anecdotally, we have seen patients with lower HER2 expression and called HER2 negative, but if you really ask the pathologist, they will find another block, and that is called HER2 positive. So I think, I'm not sure if a HER2 negative biopsy would really drop the trastuzumab in that setting. I would probably caution against it. But I think, from a biological point of view, we have a lot to learn about the mechanisms of resistance to agents such as TDXD.
Thank you. Sarah or Ron, you want to comment on your institutional practices or your preferences in terms of biopsies, ctDNA, at what lines do you repeat them, and what use do you see for them?
Yeah. It's not common for us to rebiopsy, though if it's clinically feasible, it may provide you with a little bit additional information. On the triple positive question, I'm certainly bringing in the hormonal therapy as much as I can, particularly as a maintenance therapy, because that could help you maintain a long progression-free interval.
I would say clinically, if I have a patient that has pretty rapid progression on a drug with HER2-positive metastatic cancer, say they have progression within 6 months of TDXD or within 3 months of TDM1, I'm going to be a little bit confused about their HER2-positive status, and I would rebiopsy them to understand what their IHC was, and I would order FISH. And in later lines of therapy, when you're just looking for more options, running next generation sequencing after several lines of therapy, it can be really helpful. You might get really lucky and have a TMB high patient. I have a HER2 positive patient on 9th line therapy at a TMB of 60, and she's been NED on Pembro for 2 years now. So I think biopsying for NGS makes sense when you're looking for subsequent therapies, and repeat HER2 when you're confused about how they did on the HER2 targeted therapy.
Okay, thank you. I want to ask you, Lisa, about a patient's perspective on us when we go to them and say we want to biopsy them time and again. It could be the liver, it could be another internal organ, so it's not a simple, straightforward procedure. It's, of course, largely safe, but it's also could have complications. And sometimes we're looking for something specific, but sometimes we're trying to increase our knowledge and, of course, many times research. What is the patient perspective on that? Are we asking patients for too much? Do we explain? When we explain it, how does the patient receive that?
Well, of course, with my diagnosis, I've had a number of biopsies, lung biopsy, several, and the type of person, I went all in. I'm going all in, and to me, it's not asking too much. I'm willing to go that next step for my diagnosis. So, I'm the type of person that's bring it on.
That's, wonderful. It's a matter of explaining it to the patient why we're doing it and how important it is. And what you're saying is the patient is willing to do whatever it takes, whether for their own health or to help with research.
Absolutely.
Excellent, thank you. Dr. Al-Kanani.
Wonderful talks, really covering from basic to clinical. I do have 2 questions, one basic, one clinical. The clinical question really is about the HER2 enriched subtype within the BAM50. So we've, been using luminal A versus B for chemotherapy in the ER positive, and now we're having more of these basals that are, getting more immunotherapy. We're seeing some benefit in the ER positive with low ER. The HER2 enriched plays a factor, or going to play a factor in our treatment of HER2 positive breast cancer. And then the second question is about the HER2 amplicon itself. If there's any data about different intratumoral heterogeneity, depending on the type of the HER2 amplicon, whether it's a BFB, breakage fusion bridge cycles, or extrachromosomal DNA, or chromothrepsis events, and how that factors into ITH. Thank you.
Okay, thank you. So, Ron, you want to take the amplicon and heterogeneity question, and then we'll go back to the intrinsic subtype with views from the battle.
Okay. So on the amplicon question, there is a considerable range on the size of the amplicon. Some of the amplicons can be relatively small, some can be more extensive. I do remember a presentation maybe almost a decade ago by Dennis Slayman, where they were talking about inclusion of cases where the amplicon included the TOP2 gene, I think it was TOP2A, if I'm remembering correctly, and looking about an anthracycline sensitivity. I really have not seen a whole lot about the impact of the size of the amplicon more recently, so we don't consider that as a major clinical factor. The HER2 enriched I'll leave to others.
Okay, I think that was for you, Sherene.
So I can comment on extracellular DNA. So I believe there will be a talk in the plenary session tomorrow that may encompass some of that, but certainly it does seem to be a factor of resistance. Just with regards to the amplicon, so we did present some data a long time ago with the affinity data, which showed that if you have concurrent TOPO2 and HER2 amplification, so a large amplicon, you had a better response to the combination therapy. So there's something there maybe important. HER2 enriched, I can't really comment on how it's going to be used in the future, but certainly there are trials looking at its clinical utility, and we know it's associated with a higher rate of PCR in the neoadjuvant setting, but sometimes it's associated with a worse outcome in the adjuvant setting. So it's a little bit unclear how we can use that data to help us, but certainly we can pick a patients that do respond well to neoadjuvant treatment with that assay.
Cool, awesome. Next question, go ahead, please.
Hi, Ada Wax from Dana-Farber Cancer Institute. This is a question, I think, for Dr. Loi. So you showed some of the data from Impassion 050, how it was sort of very negative trial efficacy-wise, and then there were the increased number of grade 5 adverse events in the investigative arm. And also in the first-line metastatic trial, that was closed early because of poor accrual and increased grade 5 AEs in the atezolizumab arm. And I'm just wondering if you have any ideas about what the mechanism might be. Was that just bad luck? Is there actually something about the immune mechanisms of these HER2 targeted therapies and atezolizumab in those two trials that led that to happen? Because obviously I agree with you, it's incredibly attractive and exciting. We want to be combining immunotherapy with HER2 targeted agents in very rational ways like you laid out, but it was concerning to see those toxicity signals.
Yeah, I agree with you. I don't have any other answer apart from the fact that overlapping toxicity and the excessive diarrhea and myelosuppression that went along with the addition of atezolizumab to the chemotherapy and pertuzumab combination. So I think, that's kind of not going to be the partner of choice with the PD-1 agents, but certainly it was well tolerated with TDM1. The only adverse event there that was a bit surprising was thrombocytopenia, but certainly that seemed to be efficacious, which is why it's gone to a phase 3 study. And I think with the newer ADCs, which are less myelosuppressive, have less overlapping toxicity, I think it's going to probably work quite well and allow patients to get away with less adverse events such as alopecia and myelosuppression, particularly if we pick the patients well. I think it's going to work pretty well.
Thank you.
Thank you, Dr. Wax. Go ahead, please.
Hi. With these new effective drugs, is there any room for MRI in the follow-up of asymptomatic patients?
For CNS mets, right?
Yeah, brain MRI.
Dr. Sammons?
That's a very good question. So currently in our guidelines, we do not do screening MRIs to look for brain metastasis in advanced HER2-positive breast cancer. And given that we do have these drugs that improve overall survival in these patients, the question is, should that change? I think there's a lot of things to think about. Is screening for asymptomatic brain metastasis going to impact outcomes? If we intervene on them earlier, will we actually impact outcomes, improve morbidity? I don't think we know the answer to that. We do have a prospective clinical trial open, screening about 200 patients with higher risk disease, including HER2-positive metastatic breast cancer, looking at what are the rates of detection, but also more importantly, are we actually going to improve outcomes if we detect these small HER2-positive brain metastases, which we don't know the answer to, but we do have a trial.
Great. I think, go ahead, please, then we'll have you.
For patients with isolated leptomeningeal metastasis, what is the best option now? After this morning have result of the HER2 CAM02, what will be the best option for isolated leptomeningeal metastasis? Only no brain parenchyma lesion.
Was the question for HER2 positive leptomeningeal
Yes, for HER2
metastasis?
positive.
Yes, perfect. Well, I think we have two choices. I mean, the data is limited for TDXD, but we do have our case series, and then there's a Japanese case series that included about 18 patients or so with HER2 positive leptomeningeal disease that you could look at that actually shows quite favorable outcomes with TDXD for HER2 positive leptomeningeal disease. So I do think that's a good option. And then we do have some data from a small TBCRC study in HER2 positive LMD with HER2 Climb. And they actually looked at the compound within the CSF, and tucatinib does get into the CSF. So there would be two options. You know, our patients with leptomeningeal disease, time is of the essence. And as we certainly don't have a comparator of TDXD versus HER2 Climb. But if I needed a robust response and I was very worried about them, I might lean towards TDXD first, but either TDXD or HER2 Climb would be good options.
Thank you.
Okay, thank you. Go ahead, please.
I have two clinical questions. The first is about the patient who would have met criteria for having HER2 positive early stage disease before the ASCO and NCCN guidelines changed. For example, somebody who had a ratio greater than 2 and now has a ratio greater than 2 but a copy number less than 4. Would you give that person neoadjuvant or adjuvant anti-HER2 therapy, or would you give them a CDK inhibitor therapy since they are no longer classified as HER2 positive?
So may I clarify the question a little bit? That patient is diagnosed now after the guidelines
That's right.
changed? Okay.
Diagnosed, but they would have been classified as HER2 positive. Now they are classified as HER2 negative. They would have been eligible for all of those landmark studies.
Understood.
Now are not.
Understood. Dr. Bose, your thoughts on this?
Is that Steve Sorcher?
Yes?
I recognized you, Steve. All right. I knew you'd get us. So I think I would treat on the basis of the current classifications and current diagnosis of the patient. I'll kind of just make that generic statement.
Yeah, I mean, I think that obviously they have loss, right? So LOH or something like that. So they're not really HER2 driven, in my point of view. You would be looking at the IHC as well, and presumably that might be a +2. So I don't think they would be truly HER2 driven, no.
The second question is, you know, the neoadjuvant and adjuvant HER2, anti-HER2 therapy is so incredibly impressive. Are there patients that you would give extended endocrine therapy to? Do we have long enough follow-up to know that extended endocrine therapy might offer only a minimal benefit in patients with early stage HER2 positive disease now?
Another really good question. Sarah, you want to take a crack at that?
Thanks.
You're welcome.
I mean, in my opinion, extended endocrine therapy has marginal benefits to start with for whether you have HER2 positive or HER2 negative disease. I am not aware of any data on the benefits specifically for the HER2 positive population. Certainly, if a patient has a pathologic complete response to neoadjuvant therapy, I'm not going to offer that patient extended adjuvant endocrine therapy. If they don't have a PCR and they have substantial residual disease and high-risk clinical pathologic factors, and I really just want to do whatever I can to reduce their risk, that would be more of a patient that I would consider extended in. But I don't really have any data to drive that decision-making.
I guess kind of what I was asking is, do we have long enough follow-up with the landmark anti-HER2 therapies to know whether eventually they tend to recur and that recurrence could be mitigated with extended endocrine therapy?
I think the short answer to that is no, we don't have that data yet. But I agree with the assessment that I think you go risk-based and you are hoping that that extended adjuvant, whatever small benefit it could offer is really to the patients who are more likely to have events and reducing them.
Thank you both.
Thank you. Next question, go ahead, please.
Anita Kalukian from Principal Scientist at CGen. So my question is to the whole panel. Actually, I have two questions, but I'll start off with the first one. Is there any data, either preclinical or clinical, that supports a regimen that is inclusive of tucatinib in the prevention of CNS mets, either in patients that already have them or in patients that don't have them and have an intact blood-brain tumor barrier?
Okay,
Yeah.
Dr. Sammons.
I can take that as primary and secondary prevention are research areas of mine. The short answer to your question is no, we don't have that data, but there's Compass RD, which is a randomized phase 3 clinical trial that's ongoing, looking at TDM1 with or without tucatinib in patients with residual disease and HER2 positive early stage breast cancer. And one of their secondary endpoints is development of a CNS event. So we will get that data. The only other data that we have is actually from Extenet. So Extenet did a nice analysis with 1 year of neratinib after trastuzumab, and they did look at CNS events. And particularly in the residual disease population, there was a reduction in CNS events with an extra year of neratinib. So I'm hopeful that tucatinib will show the same thing, and we'll have that answer in the next couple of years.
Okay. And then my second question is this, and it's actually a controversial one, and it's for Dr. Bose. So we tend to talk about efflux as a mechanism of resistance to ADC payloads, and we think about bystander activity as a positive feature of our ADCs. So here's the question. Efflux kind of pumps out the payload into the into the tumor environment. Could that be the equivalent of bystander activity and actually be a new susceptibility for the tumor if the tumor is heterogeneous in its expression of the target that the ADC targets?
I think that's going to come down to a quantitative issue, and that, how much efflux are you talking about? How much does that impact the payload's efficacy on the initial targeted cell versus the surrounding cells? So I can't give an absolute answer on that.
Yeah, okay, thank you.
Okay, do we have, well, maybe one more quick question.
Okay.
Go ahead.
I'll make it quick. My name is Yuzan. I'm a PGY2 internal medicine resident from Wayne State University. My question is for all panels. So we have such great data from TDXD in active brain metastasis patients. So what will influence your practice if the patient come in with like neurologic symptoms? Will that affect your choice, like go for the SRT first or go for a systemic treatment first? Thank you.
Yeah, it's a good question. I think right now, if you're thinking about deferral of local therapies for systemic therapy, it really needs to be in an asymptomatic or very minimally symptomatic population, just because, I showed intracranial response rates of HER2 climb and TDXD around 50%, and so that's really kind of a toss-up, whereas we know that local therapy is extremely effective with about 90%, efficacy and local control, and so I would be really cautious to defer therapy in someone that is symptomatic, and I'd call my radiation oncology friend.
Okay.
Thank you.
And that'll be the last word. With that, I want to thank our fantastic panelists for this great educational session. This concludes educational session number 7. Thank you all for your attention.